My name is Jen Howell. I am OBGYN faculty here at Duke. I'm pretty new to Duke, but I'm not a new OBGYN. I've been practicing in the Triangle General OBGYN for about 20 years. And I've been teaching preclinical medical students for over a decade down the road at the different color blue. I'm really excited to be here, and I'm going to give you a couple different lectures this week. With that, I will let Holly introduce herself.
Yeah, all right, you can. I was wondering if this would be okay. I'm Holly. I'm one of the clinical pharmacists here at Duke. I am currently in the lung transplant clinic, but I also do population health and family medicine, and I've given this lecture for the last 2 years. This will be my 3rd year in person, which is fun. And I also do the hormonal contraception boot camp lecture as well, so I'm excited to be here.
So we don't really have any disclosures, although I think I forgot to add, which is this is a positive disclosure for you guys because I do a lot of editing and question writing for USMLE and ScholarRx. So I like to think that that gives me a little bit of an inside track on what's on your exams, but I can't promise anything. This is something that you'll see a lot this week. It's just an acknowledgement that language is important for sure, but we don't always get it right. We will do our best to use inclusive language. When we say things like male and female, we're typically talking natal sex at birth, which assumes female anatomy and chromosomes and hormonal milieu. Understanding, of course, that even with biological sex, there's a spectrum, right? There are intersex patients. Sometimes it's shorthand, but we do understand the nuances. You'll see us, not in this lecture, but you'll see us use the term maternal mortality. And this acknowledges, of course, that there are pregnant people that don't identify as mom or mother. But these are terms that are just embedded in our literature and our discourse. And so we want you to appreciate that we do understand that there's a spectrum. Same with race. I don't think we talk about race much in this lecture, but we talk about race a lot when we talk about epidemiology and prognosis and risk and things. And it's a proxy for so many things. In general, it's a social construct, but it can sometimes be a proxy for ethnicity, which may have some genetic factors in it. But usually it's a proxy for individual and systemic racism effects. And so there's a lot in that. So we just want you to understand that we appreciate the nuance. When we say race, we are not meaning that it is a genetic difference between groups of people. So here are our objectives. I won't necessarily read them to you. But this is what we're going to be talking about this morning. There's a lot of different contraceptive options. And really, we are going to leave some things out. We're mostly doing estrogen and progestin containing contraceptives and IUDs. We're not going to talk about barrier methods, about natural family planning, things of that nature, sterilization. So it's not even comprehensive because there's so many different contraceptive options. I like this little cartoon. I think it's from Sketchy, maybe. I don't know. But it kind of is a funny way of thinking about all the different mechanisms that we take advantage of to make contraception work, right? So you see the little sperm, WTF, let us in, the thickened cervical mucus that we get with progestin contraceptives. Or, the sperm is confused and poisoned when they get inside the womb for the IUDs. Or, I'm going to stay right here, the eggs in preventing ovulation. So those are kinds of the different mechanisms that we take advantage of. You do have to understand the menstrual cycle to understand how we prevent ovulation. So you remember sort of that functional connection between the hypothalamus, the pituitary, and the ovaries, the HPO axis. And we take advantage of high levels of estrogen and progesterone, which negatively feed back to the pituitary and prevent release from FSH and LH. So no LH, no LH surge, no ovulation, no FSH, no follicular recruitment and maturation. So we're kind of going to introduce each form of contraception with a little case. So Lulu is a 31-year-old. She's been on OCPs for years. She's just back for her preventative exam. She's healthy. Her BMI is 23. She's sexually active with males only, and she just wants her medication refills. And so with that, we'll introduce to you combined oral contraceptive pills, often shortened to the pill. You'll sometimes see this abbreviation COCPs, which means combined both estrogen and progesterone containing pills.
And if I remove my mask.
Yeah, go ahead.
All right. Okay, so what is in the pill? We've already alluded to, there are an estrogen component and a progestin component. It's important to know that these are synthetic hormones, so they're not exactly the same as your endogenous hormones. So I have this really fun picture that will incite some horror of organic chemistry, but is not for you to memorize or know anything about. It's just to show that the structure is very similar. There's some slight nuances, but it actually makes the estrogen component a very powerful agonist at the estrogen receptor. The main type of estrogen that you will see in the combined oral contraceptive pill is ethinyl estradiol. Older formulations had a form of estrogen called mestranol that was converted in the body to ethinyl estradiol. And then there's a few newer products on the market now that have different, slightly pharmacologically enhanced types of estrogen, but I would say overall 90% of your estrogen is going to be ethinyl estradiol, and you'll see it abbreviated, especially on packages, as EE. There's also a differentiation between high-dose and low-dose products. Most of the products are going to be less than 50 micrograms today, knowing that this type of estradiol is very, the higher doses have produced more hepatic metabolism and increasing your thromboembolic properties. So we've found that products less than 50 micrograms are just as effective and safer. But even today, most of your products are even mostly effective in that 20 to 35 microgram range. And then you have your low products, which are usually in that 10 microgram range. For the progestins, it gets a little bit more complicated. This, as you know, on the market, there's over 200 products available. And really, when you're thinking about side effects and how to pick a product for your patient, then you're thinking about the progesterone component and how that might work. So there's 4 different generations of progesterone, and it really doesn't mean anything. It's just kind of how they came out in the market. So your first generation is the older, and the 4th generation is newer. But they each have slightly different properties to them. But typically, your first and second generation are still very well tolerated progesterones. On these slides, I have longer half-life. Basically, what that means is just gives a little bit more leeway for variability. If you're not taking it every 24 hours, you still have that protection. So longer half-life is good. And then when you get to the 3rd and 4th generations, you're thinking these are not only working on the progesterone receptor, but androgenic receptor and mineralocorticoid properties. So these 3rd and 4th generation progestins have a little bit less androgenic side effects, so acne, oily skin, even helping with reducing fluid retention. But these products are also, estrogen and progesterone are pretty much like a yin and a yang. So when you get to these 3rd and 4th generation, they can actually enhance the estrogen, so they can be more synergistic, which is, there's been some claims out about increased thromboembolic properties. All right, so all of that fun stuff to know, what's the mechanism of action, how do they work? So we've talked about the menstrual cycle. Really, it's keeping that negative feedback going so that you have that you're kind of like a sustained luteal phase. And with the estrogen component specifically, it's suppressing the gonadotropin-releasing hormone and suppressing FSH, and therefore reducing ovulation. So that's really the main mechanism of action of all your oral contraceptives, is to reduce or no ovulation. Where the progesterone component may thicken the cervical mucus, like we already mentioned, making the endometrium kind of atrophy, so a less lush environment, and impairing that tubal motility, so where they don't know where to go. The really fun part of being a pharmacist is knowing how medications are metabolized, because that can be really important for how effective the medication is. So when you think about hormones, giving hormones orally is never really something that's done because hormones are very oily, and so your body won't absorb them very well. So these hormones, these synthetic hormones, are changed so that you can actually get them into the bloodstream. But then once they're in the bloodstream, they're metabolized again through the liver. So when we think about these hormones, they're more, these synthetic versions are more lipophilic. And if you have any malabsorption, so like a Roux-en-Y gastric procedure, or where someone's vomiting or having a lot of diarrhea, it can actually decrease the effectiveness of the product. And then there's a lot of controversy about obesity. There's still a lot that we don't know, we haven't studied. But a lot of times these oral contraceptives were studied so long ago that they didn't include this patient population. So you'll see a lot of limitations as well there. As far as metabolism with oral products, you're gonna have extensive first pass metabolism of the estrogen, so you're gonna have to use larger doses of estrogen to get the same type of effect in the bloodstream. And then ethinyl estradiol specifically is metabolized by P450 cytochrome enzymes, which you will hear a lot, and that really just should like raise your flag for drug interactions, mainly with like seizure medications like carbamazepine and lamotrigine, topiramate. So the drug-drug interactions can decrease or increase the metabolism of your oral products. Now there's lots, like I already said, over 200 products, so how do you pick one? We have monophasic products where you have a sustained level of estrogen and progesterone during the whole time, and those can be extended cycle where it's usually 21 days of active pills and 7 days of placebo to induce the menses, or you can have extended products which are like 24 days or even continuous cycle where there's no placebo at all. Biphasic, triphasic, and quadphasic are typically where you'll have varying levels of hormones, and the quadphasic specifically has varying levels of estrogen and progestin. So it gets super complicated, but really when you're thinking about how to adjust for side effects and things like that, it gets more complicated when you go into the biphasic and triphasic and quadphasic. And when you look at all of them together, there's no difference in effectiveness. So it's really more of just a patient preference and trying to get them a product that they want to meet their lifestyle. And this is kind of a fun slide, because we got asked a lot about, well, what about male hormonal contraception? Currently, there are no oral products on the market, or there's no products for males in general, but how would this work? So this has been studied, and there's over about 40 years of literature available, but there are no products on the market currently. Really, it would be using a progestin component to reduce the gonadotropin-releasing hormone, to reduce sperm synthesis, but also would be reducing testosterone. So then you combine that progestin with an androgen to give that peripheral androgen effect still, so they're not losing that, but then they're reducing the sperm count. And really what we've seen so far is that we haven't really proven efficacy or safety for these products to come to the market. So there's none out, but there are some non-hormonal options that are being looked at as well. All right, back to body and disease.
I suspect Holly knows a lot more than I do about the pharmacology of the male contraceptives, but I feel like fairly recently there was a product that came to the FDA for approval that had reasonable safety and efficacy, but the FDA declined to approve it because it had too many side effects. Just saying. So, what are the risks of combined oral contraceptives? There is a VTE risk, so venous thromboembolism, and that's driven by the estrogen dose, so it's dose dependent with the estrogen. The other things that make a patient more at risk for VTE play into who you might choose estrogen-containing pills for. So older patients, higher risk, BMI, higher risk, higher BMI, higher risk, patients who smoke. I think this graph here it puts it in perspective and is a good counseling tool. So this is the incidence of VTE per 10,000 women years. And if you see, here's the use of OCPs, and then look at pregnancy and postpartum. So you got to put it in perspective, right? Like you have a 3 to 5 times higher risk of getting a VTE just from pregnancy than you do from oral contraceptives. And I find that really resonates with patients and puts the risk in perspective. There are some other more rare risks, cardiovascular risks, stroke and MI. Your average woman is not at risk for these things. It's typically women who have, kind of vascular abnormalities such as long-standing diabetes, hypertension. The big one is smoking, age greater than 35. We see this sort of idiopathic MI increase in those patients. And then migraines with aura. There's something vascular there that goes on that makes these patients at higher risk of stroke, not MI. So we don't use combination oral contraceptives in patients with migraines with aura. Other kinds of headaches are okay. Migraines without aura is okay, but not with aura. In terms of neoplasm, I usually tell patients, hey, pills are kind of cancer neutral. There is a well-documented decrease in ovarian and endometrial cancer. In fact, we use oral contraceptives in patients with BRCA gene defects to decrease their ovarian cancer risk. The cervical cancer risk is probably increased as best as we can tell, although of course now we have the HPV vaccine that can mitigate that. It's hard to know, but we think that the estrogen component everts the transformation zone of the cervix where HPV infects, and so that's where that increased risk may come from. The breast cancer data is mixed. There is some data to suggest that there is an increase in breast cancer in current users. Of course, current users tend to be pretty young women who have a low risk of breast cancer. And it's unclear. It seems in most studies that risk after that you stop pills, it doesn't persist. But there's really mixed data with that. So overall, cancer neutral is how I put it. A lot of side effects that people will talk about, how many are real and how many are perceived is a matter of some debate. What I would say is most of the side effects are transient. The body has to get used to these essentially pseudo-pregnancy levels of hormones. So nausea, breast tenderness, headaches. You'll see that mood lability the first couple of months, and then most of the times those things get better. In terms of long-term side effects, they are weight neutral in most studies. You can use them in patients with mood disorders. In fact, they're FDA approved for premenstrual dysphoric disorder, which is a severe form of PMS. Libido, there's mixed data. As we alluded to with the male contraception, if you're suppressing ovulation, you're suppressing ovarian production of testosterone. And so there is some biological plausibility that you could decrease sex drive in women as well. However, as we'll talk about tomorrow, libido is a very complex thing. And if people now have contraception on board and they're not constantly worried they're going to get pregnant, maybe that improves libido. So it's mixed. Breakthrough bleeding, we will see sometimes, meaning bleeding not just at that withdrawal week at the very end, but bleeding some other times. In general, birth control pills, when taken correctly, are actually pretty good for cycle control, but it is something we will sometimes see. And sometimes that endometrium thins out so much from that high dose of progestin that you really don't get a withdrawal bleed. You get amenorrhea, which can be a positive or a negative depending on the patient's preference. What are the contraindications and who can you use them in? This is a really good, when you're working in like a primary care clinic or an OB/GYN clinic to kind of queue this up, you can get it online at the medical eligibility criteria for contraceptive use put out by the WHO and CDC. All the kind of major medical problems, and you can look over the column and see which types of contraception are preferred and which are contraindicated. So this is a super, super helpful thing, right? Because you could never memorize this. But we, as clinicians, use it all the time. In general, though, with estrogen-containing, so combined oral contraceptives, because of the things we talked about, women who are age greater than or equal to 35 and have significant smoking cannot use estrogen-containing contraceptives. If you have a blood clot or a history of a blood clot, if you've got significant, small vessel disease, so heart disease, diabetes mellitus of greater than 20 years duration with end organ effects, right? We think that's sort of a proxy for coronary artery disease, uncontrolled hypertension, breast cancer, if you have liver dysfunction, not just a mild transaminase, but significant liver function defects. And again, migraine with aura. This is a cute little graphic from bedsider.org, which is a nice website to refer your patients to when they're trying to figure out what contraceptive would be best for them. It puts effectiveness into really easy to understand terms. except for barrier methods, or even I mean, almost everything, if it's going to be used perfectly, is like 99%, almost everything. However, in the real world, what we call typical use. So success rates are often given to you in typical use. How do they function in the real world? And so the most highly effective contraception is when perfect use equals typical use, right? However, things like birth control pills require you to take a pill every day. And so, we're human and we forget to do that. The most common thing is forgetting to start your new pack. And then you've had 7 days of placebo and then you maybe, I'm only a day late to start my new pack. But no, you've been off for 8-9 days and you could get an LH surge. So the typical use is, somewhere between 94 and 96%. So they work pretty well, but there's some drop off from perfect to typical use. Tali alluded to this, continuous versus cyclic. Typically, here's a little picture of a pill pack. These are all active pills. And then you take away the active pills for 7 days. It's not enough time for an LH surge to happen necessarily. But what happens is if there's been any buildup of the endometrium, and there's not usually much because of that high dose progestin, keeping it sort of lutealized. But if there's any buildup and you take that hormone away, you will have a bit of a withdrawal bleed. It's not an ovulatory menses. It's fake, I tell people. It's just there to let a person know they're not pregnant. And again, just get out any endometrium that may have built up to decrease the chances that you'll get unpredictable breakdown bleeding. So you can just skip that week. Just go right on to your next pack and skip that week and continue with that endometrial suppression. This is really good for patients that have lousy periods, right? Even though the periods tend to be much better on OCPs because of that endometrial suppression, some patients still will have lousy periods. Endometriosis is a gynecologic condition I think we touch on a little tomorrow, where the endometrium sort of retrograde goes out the tubes and implants in the pelvis. And those patients essentially have like internal bleeding whenever they menstruate. So endometriosis, it's really good to skip that withdrawal week. If you've got lousy periods, just painful periods, patients will do that. And just sometimes lifestyle, they don't want their withdrawal bleed. Sometimes you will get more unscheduled bleeding when you do that, so that's a risk, but there's no medical risks. People have this idea sometimes that everything's building up, inside there, and I have to clean out. That's not true, because again, we're atrophying the endometrium. All right, so Sonia is a 32-year-old G3P3 coming in for an annual exam. She is healthy, her BMI is 26. She's a stay-at-home mom and is sexually active with males only. And she heard about the ring. Her best friend really loves the ring. What is that? Okay, so that brings us into other estrogen-containing options. When I talk to patients, I stick them all together because it's all the same mechanism, pill, patch, ring, and I talk to them about them all together. So let's talk about those, and I'll turn it over to Holly.
All right, so this is kind of fun. For a long time, we just had one patch, and now we have 2 patches. But really, what I like to point out with the patch is the dose of estrogen. So if you'll notice that the patch, Xulane, which is the one we've had out the longest, and Torilo both have 35 to 30 micrograms. And they're bypassing the oral route, so you're actually getting increased systemic exposure to estrogen. So when we think about side effects and what we'll talk about later, this really comes into play. The patch specifics is really that just putting one patch on for 3 weeks at a time and then removing the patch. If the patch falls off greater than 24 hours during that 3-week period, or if there's a no interval patch where they forget to put the patch on and it's more than 9 days, then we do need to counsel about using backup methods to prevent pregnancy. And then again, you'll see this BMI. 198 pounds, kind of hard to remember. I always just kind of think 200, but it just wasn't studied in that population, so there's a possibility for decreased efficacy.
It should say BMI greater than 30.
Oh, yes. I corrected that last year.
Typo, sorry.
Okay. Sorry about that. Greater than 30. And then the vaginal ring, same thing, but again, notice the doses of estrogen are almost half of what you'll find in the patch. So. And then the progesterone component, so we have the NuvaRing, which is now generic. It's been out the longest. We have a newer one, Annovera, which has a different type of progestin, which is actually in that later generation category. So for NuvaRing, it's one ring for 3 weeks and then remove for 1 week, but it can be used continuously. With Annovera, it's the same ring the whole year, and we don't have enough data yet to know if we can use it continuously. There's a possibility that if you used it continuously, it might not last for the whole year. So that isn't recommended currently. The exact position of the ring doesn't matter. I usually, when I'm counseling patients, just say that you shouldn't be able to feel it, and also reminding them that it is vaginally. We've had instances where people have worn it like on their wrists, so we definitely counsel that it is vaginal. And like I said, with the off-label for continuous dosing is not for Annovera. Again, they bypass first-pass metabolism, which will improve absorption. And then when you think about variability with oral, like if you're not taking it at the same time every day, there's a lot less variability if you give something transdermal. You get these sustained levels, so potentially you have less risk of having like an unintended pregnancy. A reduced dosing frequency can really just increase convenience and adherence. You're not having to remember to do something every day, but you are having to remember to do something like every 3 weeks or every month, so it's just a little different.
So the reason I talk about all of these things together is that the risks are the same, right? They're kind of the same sort of product, just a different delivery system. So VTE, cardiovascular risk, are the same as OCPs, cancer neutral type of thing. Side effects, really, again, same sort of thing as you would think with the other estrogen-containing products. Contraindications, same thing, with the one exception being the patch is labeled such that you can't use it for, or you shouldn't use it for patients with morbid obesity. That is controversial. Many of the studies with oral contraceptives weren't done in patients with morbid obesity. It's hard to think of a biological plausibility reason why. Why would it be that way with the patch but not the ring? It doesn't make a ton of sense, yet that's what the labeling says based on how the patch companies did their studies. I think clinically, some people ignore that contraindication, I'm just going to say, because of the problem with the data. But just so that you know, you should know it because it's in the packaging. Despite what Holly said about the more constant levels and less to remember, they tend to fall in the same category of, they work pretty well. There is still a difference between perfect use and typical use. And so they are about the same from an effectiveness standpoint in the real world, about 94 to 96%. But for some individual patients, it really does seem to help that there's less to do. So LaToya is a 25-year-old G1P1. She's 3 weeks postpartum after vaginal delivery. She's healthy. She has not resumed sexual activity. But she feels like she's ready to again, but doesn't want to be pregnant. And she's exclusively nursing her infant and doesn't want to affect breast milk. So what would we think about for her? Well, first of all, is lactating contraception. It kind of is, actually. We call it lactational amenorrhea. When you are nursing an infant exclusively, there are signals from the constant suckling that go up to the hypothalamus and decrease that pulse frequency of GnRH and suppresses ovulation. The exact mechanism is not 100% known, but for infants less than 6 months with exclusive breastfeeding, most women will not ovulate and menstruate, and so it can be effective at contraception. The problem is, as the baby gets older and you start to supplement and give solids, at some point that ovulation suppression is going to stop, and as you know, you ovulate before you menstruate. And so it's possible, if you're just waiting for your periods to come back before you use contraception, that you'll conceive before you ever get your first period postpartum. So it's not foolproof, and there are some people who will menstruate even through exclusive nursing. But in general, it's decent contraception. But of course, at some point, you're going to click back in again. And so oftentimes, people will still want to use contraception during nursing. What we've found, based on what we know about the physiology of lactation, it seems like both estrogen and progesterone should inhibit lactation. However, it seems like it's really more the estrogen-containing medications that do it, whereas we do use, in particular, the low-dose progestin contraceptives during nursing, and it doesn't appear to affect breast milk. And so that is what we call progesterone-only pills.
So for the progesterone-only pills, which commonly you can hear referred to as POPs or mini pill, this is for the longest time, we only had one option available, which was this norethindrone orthomicronor, and it was just 28 active tablets. There are no placebo pills, but the caveat was this one doesn't have a long half-life, so if they were to not take the dose within that 3-hour window, there was potential that it decreased efficacy. So they have to be really adherent to taking them at the same time every day. And then this does have a lower dose of progesterone that you would normally see in your combined oral contraceptive pills. So like something that's really common like loestrin has 1.5 micrograms or 1.5 milligrams per day of the progestin component versus what you see in orthomicronor at 0.35. So it's a big difference. Now, to make pharmacist's life and physician's life way more complicated, we have another product out called ClinMed, really just in the last year, and this is the 4th generation progesterone drospirenone. This has 24 active pills with 4 inactive tablets, and the dose of the 4 milligrams, if you use just 3 milligrams of drospirenone, would be equivalent to 25 milligrams of spironolactone. Which is a diuretic, and it can also a potassium-sparing diuretic, so you can have increases in potassium. But this one has a lot longer half-life, so you could, you can extend that window. They don't have to take it within that 3 hours. It can be more than, that next day. So if it's greater than 24 hours since the missed pill, then they would have to use the backup method. But really what we're talking about with those synergistic properties, there is potential when you're thinking about drospirenone for an increased risk for thromboembolism. So it might not be the best option for women who are, in our patient case, for women who have just had a child or in that higher risk for VTE. Because we don't know a lot about drospirenone in that patient population. So this would probably just be more for someone who has a contraindication to estrogen and needs a progesterone-only product. Again, with the progestin component, we know that the mechanism of action primarily is that thickened cervical mucus, although with these other generation, these higher dosing progestins, we can potentially see that synergistic effect where it is decreasing ovulation. So, and it used to be that you were thinking mainly it's the estrogen component, but it is the progestin component as well. All right.
So progesterone only, these low dose progesterone only pills really don't have significant risks, no VTE or cardiovascular risk or breast cancer risk. Probably the biggest issue is irregular bleeding. There's no withdrawal week, so you might get unpredictable bleeding. It's not necessarily preventing ovulation, so you actually might have ovulatory menses through it, right? So it's kind of unpredictable in terms of cycle control. Progestins are derived from androgens, and so you can get some increased acne with the older generation progestins, and they should be weight neutral. Not too many contraindications, really. You don't want to use if you think the patient might be pregnant or has breast cancer, or maybe you're working them up from abnormal bleeding. You should know what the bleeding is before you just mask it with pills. Liver disease is relative. I mean, I think estrogen is really the hormone that's metabolized big time by the P450 cytochrome system in the liver. But in general, the hormones are metabolized by the liver, so you have to be careful if a patient had significant liver disease, even with progestin-only contraceptions. And again, especially with the low-dose progestin components, if you've had malabsorptive bariatric surgery or you're taking something that revs up the P450 cytochrome system, you really have to be careful about these low-dose progestin-only pills. They may not work very well. In general, I would say clinically, we use them more just for nursing moms because combined with nursing, it's pretty darn good. But on its own, it's got a failure rate of 5%, so even with perfect use. And anecdotally, many of us think of it as being quite higher because of the user error and the need to take it within 3 hours. The progesterone-only pills don't prevent ovulation. Again, the higher dose progestin products do in some circumstances, but not progesterone-only pills. So our next patient is Faye. She's 27 years old. She's a G1. She's just coming in for her annual exam, and she's been on Depo for 3 years and loves it. She's healthy, BMI of 23. She's concerned. She's heard, though, like, am I supposed to take a break from Depo? Is there something like with my bones where I'm supposed to come off of it? So with that, let's introduce, what are we talking about when we say Depo? It's really the depot formulation of medroxyprogesterone, meaning it's an injection that lasts for 3 months, so you get it 4 times a year. And I'll turn it over to Holly to give you the pharm.
Okay, Depo. So there's actually 2 formulations for the Depo shot. So it is kind of interesting that when we say Depo, we're talking about the IM injection. And this is a medroxyprogesterone acetate. So, I love my pictures. And you can see that really it's this acetate addition to the structure that keeps this molecule around a lot longer. So that's how they can give this injectable and then also sustained release throughout that 3-month period. The Depo sub-Q is subcutaneous injection, and then it actually allows for a lower dose because it is a much more sustained release. So it also could potentially be self-administered if someone was comfortable with that and being able to taught that if they didn't have access to a clinic. There is a formulation available. It's usually administered by the 5th day of menses in order to prevent pregnancy. So we have the IM, which is gluteal or deltoid administration, or the subcutaneous could be thigh or abdomen. I usually say like wherever you can pinch an inch every 3 months. So, and again, it's the same mechanism of your progestin. It inhibits the secretion of the gonadotropin. So you do get ovulation suppression, but it also produces that atrophic endometrium and thickened cervical mucus. Now, this is a lot higher dose of progestin. So again, you're having endogenous estrogen suppression as well. So that is potentially where we're thinking that bone mineral density loss occurs. But what we haven't seen is that it may not clinically lead to increased risk for fracture, but we do know that there is bone mineral density loss with this product. 100% bioavailability, because you are bypassing all of that, is given injectable. But whenever you give something in the muscle, it's not a very lush environment, so there's very erratic absorption and can be differences in how you redose the product. But with this subcutaneous formulation, it's less erratic, you have more sustained levels, so that's why they can give you a lower dose, potentially less side effects. Metabolism, again, the 3A4, mainly though, like we mentioned earlier with our progestin products, it's through conjugation in the liver and not as many drug interactions. And then because some of the metabolites are maybe resistant to metabolism, it can last even longer. But typically with this product, what you really want to know is that return to ovulation, because this lasts so long, can be anywhere around 10 months after stopping the injections.
So the risks are the same as the other progestin contraceptives. So we don't really see the cardiovascular or the VTE risks and no impact on breast cancer risk, with the exception of this bone mineral density, right? So at least with OCPs, if you're suppressing the HPO axis and endogenous estrogen release, you're giving the person back estrogen. But here you're not giving them back estrogen. And so you do see drop-off in bone mineral density. Actually, you see that with lactation, right? Women who lactate, it's the same sort of suppression of the HPO axis, and they are known to have decreases in bone mineral density as well. It's reversible. When you stop the product, the bone mineral density reverses. And so that's where that idea came from. Well, maybe you should stop Depo-Provera every now and then. But, these are more theoreticals. And in clinical practice, we don't see an increase in fracture risk in patients that are on Depo-Provera, and we don't see osteoporosis later on in life in Depo-Provera users. So it's kind of like, there's not really any clinical consequences. So really the bone mineral density issue is not that consequential. That being said, there is a black box FDA warning on Depo-Provera for use in adolescents. There's this concern that they're not going to reach their peak bone mineral density, but again, the proof is in the pudding in terms of clinical outcomes. We really don't see increased fractures. So I think, if it's the right thing for that patient, it is okay. So this is a little patient-facing kind of piece to remind you of the side effects of Depo-Provera. Irregular menstrual bleeding you can see with any progesterone product. However, Depo-Provera is very, 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 very suppressive. So in general, it's probably the best product out there to give a patient amenorrhea. And we take advantage of that clinically for patients with gynecologic disease. There is the bone density loss, but it's really not clinically significant. It's an injection, which is an issue for some patients. Although the sub-Q formulation is out there, it tends not to be widely available in this country. I think they use it a lot in Europe, but I have not had a lot of success in prescribing it. And there's that delayed return of fertility that you have to counsel patients about from a family planning perspective. Weight gain. Again, it's always tough to evaluate weight gain in these studies. There's so many competing variables, and what are you comparing it to? No hormonal contraception or different methods. People change methods. But I would say that for some patients, it seems like the high-dose progestins are a bit of an appetite stimulant, and you can see some weight gain with Depo-Provera. Contraindications are pretty much the same as the other progestin-only ones. You don't want to give it if you're not sure why the patient's bleeding, breast cancer, pregnancy, significant liver disease, with the exception of a patient who's at super, super, super high risk for fractures, bone disease, osteoporosis, like, for instance, long-term corticosteroid therapy. You'd think, even better. This should be a much higher success rate, but it's still kind of in the works pretty well category because people still have to remember to come back for their injection. And sometimes the less you do something, it's harder to remember. While it's close to 99+% for perfect use, there is a drop-off with typical use, and it's still around the range of 94-96% effective. So Jenny is a 34-year-old para 2 LMP earlier this month who presents for her annual exam. She's got chronic high blood pressure, currently not on any medicines, and stable depression with a BMI of 38. And she wants contraception for sure, but she has really heavy, crampy periods and would like to talk about that as well. And so with that, we're going to introduce some of the other progestin containing contraceptives that we put in the category of LARCs, or long-acting reversible contraception. These are also very highly, highly effective contraceptives as well, with the goal also of that endometrial suppression, so suppressing heavy, crampy periods. And I will let Holly take it from there. I'll just show you the pictures here. We have the subdermal implant, which is the Nexplanon. Subdermal implant, which is the Nexplanon, and then IUDs, these little T-shaped devices that go up inside the uterus, progesterone-containing ones, and then there's some that don't contain any hormone.
So the first LARC that we're talking about is Nexplanon. A lot of times some of our family medicine patients are referred to it as the arm rod, but it's a single rod implant, and it has etonogestrel, 68 milligrams. So this is a high dose, and this will last and release 60 micrograms per day over 3 years. But even 60 micrograms per day is a higher dose of progestin than you'll find in your oral products. It's inserted subdermally on usually the non-dominant upper arm and on that first 5 days of the cycle every 3 years, and the mechanism of action is similar across the board with our progestin components. But with this product, since the dose isn't quite as high as our Depo injection, we don't see a decrease in the bone mineral density. Again, 100% bioavailability, so it's going transdermally. And usually return to ovulation with this product is a lot quicker, so 7 to 14 days after the Nexplanon implant is removed. And the same metabolism, and then again, you'll see controversy with this product as well, just because patients with a greater than 130% of their ideal body weight were excluded in the trials. For progesterone IUDs, so this is a really fun part of updating our slides for this lecture, is almost every year the efficacy changes, and I have to go look up all of the, and I give the FDA approved years, but it used to be 5 and 3. I could get it and keep it, but now they all have different. So we have progesterone IUDs that have levonorgestrel is the product, the progestin that is in the IUD. I think sometimes we'll refer it to like LNG IUD, so to know that it has that progestin component. And we have 4 currently. And over time, they do release less progestin, but they're still considered effective. We have different mechanisms at play here, but Mirena and Liletta will be 7 and 6, and then Kyleena and Skyla will be 5 and 3. Mechanism of action is kind of combined here. So you have this low-grade intrauterine inflammation from the actual IUD being present, and then possible inflammation that could be spermicidal and interference with implantation as another mechanism. But the progestin component also suppresses that endometrial lining and atrophy, so it can impair implantation, but also for patients with heavy menses, this could be a good option for them as well. You can have some metabolism with the progestin component, but since this isn't the primary mechanism of action, it's not really considered clinically relevant for preventing pregnancy. All right, back to Jen.
A little slight diversion. So I don't know, a lot of patients will ask me, and this may come up in your minds as well, like, why would someone be against a contraceptive? Is it an abortifacient? When we talk about all the different mechanisms, you see we talk about endometrial suppression, right? So technically speaking, that mechanism of action, a fertilized embryo couldn't implant, right? So that is one possible mechanism. You might imagine that in vitro studies, or in vivo studies, it's completely difficult to figure out what mechanism of action is happening, right? Think about designing that study. So sometimes they're just suppositions, and we don't 100% know exactly all the different mechanisms. But that is one possible mechanism, especially of progestin-only contraceptives. But just so you know, the American College of OBGYN defines pregnancy as implantation of a fertilized embryo. That's when pregnancy begins. So, maybe this is just semantics. When life begins, obviously, is a spiritual issue, but it does not disrupt the pregnancy because pregnancy doesn't begin until implantation occurs. So just so that you know, because these are questions that patients ask, your family members ask, this is good for you to know. So Nexplanon, again, same as the other progestins, no VTE risk or breast cancer concern. Nexplanon, even though it's high-dose progestin and probably does suppress ovulation in some patients, it's pretty variable, whether it's working just by those local thickened mucus endometrial thinning or whether it's actually suppressing ovulation. So some patients will have amenorrhea, but a lot of patients don't. So this is one of the notorious ones for breakthrough bleeding, the Nexplanon. It's pretty close to 100%, for effectiveness, right? So this is one where perfect use equals typical use, and it's essentially almost it's better than tubal ligation. However, you have to warn patients that you are not going to get pregnant with this, but you need to carry around some pads and tampons because irregular bleeding is a big thing with this. Not usually heavy or crampy because it's non-ovulatory, just progestin shedding, but it can be an issue. And some acne, headache, some irritation at the site. Did you have a question?
Sorry to interrupt. Did you say it was more effective than tubal ligation?
Yeah. The tubal ligation, you can actually get recanalization of the tubes over time, believe it or not. And so, especially in a young patient. Now, an older woman who gets a tubal ligation is probably more effective. But if you take a 25-year-old tubal ligation versus a Nexplanon, it's actually more effective if you look at the stats. Contraindications are kind of as we've discussed. Again, it's probably the best product on the market from a success standpoint. The implant doesn't fall out, it doesn't migrate, it doesn't move, it doesn't perforate, which are some things we'll talk about with the IUD. You can't lose it, you can't forget it. Perfect use equals typical use. The risks for a hormonal IUD are the same. Yes, sir.
I have a question about the bar. I think a few slides back it said that you need to implant it within 5 days of like menstruation, is that like, does something bad happen or it doesn't work if you don't, or is that just the way the trial
No, I
is
think
done?
that was maybe, I don't know if that was the depot and the Nexplanon. That's just the recommendation of when you start it, for it to take effect the quickest, to suppress ovulation that cycle, right? If you started in the luteal phase, you've already ovulated and there's going to be, an egg floating around out there. And if it causes amenorrhea, you might not know you're pregnant, right? You might get a luteal phase pregnancy. So we try to put it in right at the start of the cycle so that we suppress ovulation from that cycle on, and there's no chance that they could have had an egg floating around and then they get the progestin depot, right? So it's not so that it's just to prevent luteal phase pregnancies and for it to take effect as fast as possible. Does that make sense? So the additional risks with a hormonal IUD is that it goes up inside the uterus, and it could push through the muscle wall of the uterus, especially if it's not placed correctly, requiring surgical removal, or the uterus could cramp it right out. Those things are kind of in the 1% range, but they do happen since IUDs are really actually quite popular now. And so those are some additional risks. The ectopic pregnancy, if you have a failure with an IUD, which is much less likely than if you're not contracepting, that pregnancy could be an increased ectopic risk. But in general, you're so less likely to get pregnant that ectopic pregnancy is not a risk, right? So that's kind of hard. That's semantics-wise, that's difficult to explain sometimes. You're not more likely to get an ectopic pregnancy with an IUD in. You're much more likely to get an ectopic pregnancy if you're walking around not contracepting. But if you do have a failure, there's a higher risk of an ectopic. Hormonal IUDs, you can get that irregular progestin breakdown bleeding, but they're pretty good for inducing amenorrhea, better than the Nexplanon. You can get some cramping, especially initially, but we use hormonal IUDs, the progestin IUDs, to help patients with heavy cramping periods. So for our index patient, she would be a good candidate. The contraindications are the same as we've been discussing, with the exception of, since we are putting something up inside the uterus, you've got to think about if the uterine cavity is really distorted. Common things with that are Müllerian abnormalities. You may have learned or heard about during embryology. If the two Müllerian ducts don't come together, you can get like a duplicated cavity or a heart-shaped cavity, and so you can't get an IUD in there. Or a patient with fibroids, which we'll talk about tomorrow, big muscular tumors that push into the uterine cavity. They can make it difficult to place, more likely to get perforation or expulsion. The other important thing is you can't put it in an infected uterine cavity. So if you have a suspicion that that patient may have an infection based on physical exam or symptoms, you do need to wait for that infection to clear or get some confirmatory data before you put it in. It is a highly effective reversible contraception, and so perfect use pretty much equals typical use, 99+% perfect and typical. The only reason it's slightly less than the Nexplanon, which we're talking 0.00 something % less than the Nexplanon in terms of effectiveness, is because of perforation and expulsion. So Maria is a 34-year-old G4, P4, coming in for her preventative exam. She's got a BMI of 31. Married, doesn't smoke, and she wants reliable contraception that's easy, but she doesn't like the idea of amenorrhea. And a lot of patients don't. They're paranoid they're pregnant every month, or they just, even though we explain to them that nothing's building up or backing up, they just, culturally, they feel like they need to have a period every month. So that's an important thing to elicit from patients when you're trying to figure out what contraceptive is right for them. So that's where the copper IUD comes in. It's actually spelled Paragard without G-A-R-D. I don't know what we were trying to say right here. That's some butchering of like security guard. I don't know, that's typo. But it's Paragard, G-A-R-D. And it also goes up in the uterus, and I will turn that over to Holly to discuss how it works.
So this will be fairly quick. So this just kind of shows you where the copper coil is located, up on the T-shape and down through the rod as well. And this one is left in place for up to 10 years, so this is our longest IUD that we have available, and it's also approved for emergency contraception, which also differentiates that from our hormonal IUDs. And then the mechanism of action, really same thing with our hormonal IUDs, except for you're removing that atrophy so that they would have a period every month. Supposedly also, from clinically what I've heard, they can actually have increased bleeding. But really just thinking about that low-grade intrauterine inflammation, as well as the spermicidal or impaired sperm transplant with the copper IUD, and then interference with implantation are the main supposed mechanism of actions.
So you still have the expulsion and perforation risks, and again, not an increased risk of ectopic pregnancy a priori, but if you have a failure. Yes, the periods tend to be heavier and longer with the copper IUD. So in terms of contraindications, it may not be a good idea to use that in a patient that has baseline heavy periods or is on an anticoagulant. The other additional contraindication is not something you see every day, but Wilson's disease, which I think is like a copper storage disease or a copper allergy. I actually think liver disease should be struck from this one, right? So cross that out. That was a carryover for hormonal ones, so it should not be an issue with copper. It also is highly effective, with perfect use and typical use being pretty darn close together at 99+%. And that is all we got for you. Questions about anything? Yes, ma'am.
When you're talking about how patients come in and like think that it's healthy for them to have a period, that resonated with me because I've definitely heard that myself.
Yeah.
And I'm wondering if there is any truth to like some kind of like bone health or something like that that a person has when they do have their period, or if really that's all a myth.
No, there's no bone health concerns because, especially with combined OCPs, we're giving you back the estrogen that we're suppressing. So I think the confusing thing for patients is like, we'll say like, oh, you're not, like people who are walking around and 25 years old and you're not having your period, 6-8 months, no period, that's a problem. And sometimes we use, you get that sort of endometrial buildup, and you can get endometrial hyperplasia and big bleeds. And so we'll sometimes say, oh, you got to clean that out, or you have to have a period. And so that's then confusing to them to then say, oh, but it's okay. We can give you something that stops your period. So that's very tough for patients to understand it. And it has to do with the endometrial atrophy that we're inducing with birth control pills. It's a fake period, is what I say to people. We just pull the hormone away and a little bit comes out. Sometimes nothing comes out, depending on the patient, as opposed to kind of lush estrogen without any progesterone when you're not ovulating, that builds up over time. But it's a hard concept to get across to patients. And ultimately, again, the best contraception for a patient is the contraceptive that they'll use and they feel comfortable with. So if patients want a period, they want a period. All right, great. Thank you, guys.